So welcome to our fourth webinar, the Stroke Ed webinar for November 2025. I'm pleased to welcome Sandhya, who's in Toronto at the moment. I'm here in the eastern part of Australia on the Central Coast, and I would like to acknowledge the traditional custodians of the land on which we meet, and I pay my respects to elders, to First Nation elders, past, present, and future. I'm Annie McCluskey. I'm one of the Stroke Ed directors, and I've been wanting to hear more about how we can combine motor training with sensory training, having done Leanne Carey's sense training program a few years ago as a workshop. And I've been trying to implement some of those ideas in my own training at workshops and clinically, but it's good to have somebody who's done that as research. So Sandhya completed her research, her PhD research here in Australia at the University of Newcastle. She's now at the Toronto Rehabilitation Institute, as you can see, following on from her work. So I think I'll hand over. The Q&A at the bottom of your screen is where you please should type any questions you might have. Please don't use the chat. And we will stop at intervals along the way for any questions. The recording will be made available and a link sent to you sometime in the next week and will be kept in our library after that time. So over to you, Sandhya.
Thank you very much, Dr. McCluskey. So thank you very much for the introduction and for inviting me to share my research today. I have a very keen interest in multimodal, multi-domain interventions in neuro rehab, and more specifically combining somatosensory and motor training with the aim to improve upper limb recovery after stroke, which is what we'll be talking about today. So by the end of this session, you would have learned about why somatosensory rehabilitation is important to motor recovery after stroke. I will also be discussing a few rehabilitation strategies that combine movement and somatosensory training after stroke. And I will also briefly discuss how to structure feedback delivery during motor and somatosensory training. So we know that stroke can happen as a result of a blocked blood vessel, or it can happen also as a result of a ruptured blood vessel, which in both cases lead to brain cell death. So stroke is a very, very serious concern worldwide. We know that stroke is the leading cause of disability amongst adults worldwide, where every year 15 million people suffer a stroke, out of which a third remain permanently disabled. So after a stroke, people experience deficits, both motor and somatosensory deficits in their limbs and in different parts of their body. More than 85% of people who experience a stroke have motor impairments. And this involves changes in the kinematics of reach to grasp, for instance, and this includes the movements become slower, the peak velocity becomes slower, the deceleration happens over a longer duration. The extent to which they open their grasp, that is their grasp aperture, also reduces. And there's also difficulty in adjusting the amount of grip force or grasp forces when interacting with objects. Of those who have got motor impairments, 50% of them also have somatosensory impairments. And this includes impairment of touch sensations, which eventually leads to the reduced ability to detect and interpret tactile cues when interacting with objects with different surface properties. This also leads to impaired recognition of objects through touch sensation. So combined motor and somatosensory impairments lead to poor object handling and manipulation. And this can be observed, for instance, when you're trying to reach for an object, there's difficulty in reaching to the object. When the person is holding an object in their hand, they might not be applying sufficient amount of pressure such that the object slips from their hand, or maybe they are over compensating and applying too much pressure such that the object crushes. Or it might be difficult for them to sustain the amount of pressure on the object in a consistent manner, which could lead to an unstable grip. So this brings us to our first objective. Why is somatosensory rehabilitation important to motor recovery of the upper limb after stroke? So somatosensory function has a very critical role in motor control of grasp and is tightly coupled in action. So both somatosensory and motor function are tightly coupled in action. And effective grip force is the result of a complex interplay between the somatosensory and motor function. That is, there needs to be a close interplay between the somatosensory feedback signals and the modulated muscle activity in the hand and the arm. So when it comes to the development of grip forces, somatosensation contributes to the ability to control a pinch grip, for instance. It also helps to sustain and adapt grip forces when interacting with an object, especially when there's no vision. For instance, if you're holding a cup with a drink in it and you're having a conversation, you're not necessarily looking at the cup, but you're still able to hold onto the cup because you're able to sense the amount of pressure that you need to apply onto it so that it's safe in your hands. Somatosensation also contributes to the ability to manipulate objects, which includes the ability to discriminate between different surface properties, and also adjust to different conflicting conditions, such as holding onto a rough surface or holding onto a slippery surface, like a wet soap, for instance. So the appropriate selection of grip forces is largely determined by the object property, including the weight, the slipperiness, the shape, or the weight distribution of the object itself, and also the points of application of these grip forces, for instance, where your fingers are on the object, as well as the magnitude of the forces and the direction of these forces. So in order to produce effective reaching and object handling, there needs to be a close interplay between the motor and the sensory motor networks. This would lead such that there is a simultaneous activation of the integrated somatosensory and motor networks. So for there to be an improvement in upper limb recovery, motor and somatosensation function need to be improved simultaneously. Now, even though motor and somatosensory functions are tightly coupled in action, traditionally motor interventions are delivered separately from sensory interventions. So the interventions to improve motor functions have disregarded the beneficial effects of sensory training to enhance motor function, leading to a failure to maximize gain. And this could be because the sensory and motor networks are not optimally activated. So we hypothesized that by combining somatosensory and motor training, this could lead to a simultaneous and optimal activation of the sensory and motor networks, leading to stronger connections between the somatosensory and motor cortices, leading to improved upper limb recovery. So we'll take a moment to see if there's any questions so far before we move on to the second objective.
There aren't any questions, but I'm going to ask you one, which is always I've always been curious about. I tend to talk about sensory retraining, and you and Leanne and others talk about somatosensory training. So why do you use that longer term rather than just sensory retraining?
Yeah, that's an excellent question. So when it comes to sensation, there's different types of sensation, right? It goes from taste, like your vision, your touch, auditory, whereas the somatosensation, specifically, we're referring to bodily sensation, especially with regards to touch and proprioceptive. So in my work, I don't necessarily focus on auditory sensation or taste sensation. Because sensation is a quite broad term, so that's why I restrict it to somatosensation.
Thank you. And could I ask you just to slow down a little bit, just so that if there's any connection problems, we don't miss too many of your important words.
Okay, absolutely. Thank you. All right, so this brings us to objective 2, which is where I'll be discussing a few of the rehabilitation strategies combining movement and somatosensory training after stroke. So I will be presenting essentially 3 studies in this part of the webinar. So a few years ago, we conducted a systematic scoping review looking at combined somatosensory and motor training to improve upper limb function after stroke. And the aim was to try to see what are those combinations and what are the training components that were included in those in those interventions. And we also wanted to know about the efficacy of those combined interventions. So in this systematic scoping review, we included studies that delivered active motor training and active somatosensory training. For instance, by active motor training, I mean exercises where there's voluntary muscle contraction that's initiated by the central nervous system. We also included robotics that delivered assisted active movements, as well as electrical stimulation if they're combined with active exercises. For the active somatosensory training, sorry, there's a typo there. The motor shouldn't have been there. So for active somatosensory training, we included strategies that involve manual and active exploration using the hand. For example, exploring different surface textures and basically different surface properties of these objects. And we also included studies that trained for spatial detection of joint and limb positioning. We excluded passive motor training, which included strategies that initiated muscle contraction, but that were not triggered by the central nervous system, such as electrical stimulation. We also excluded passive movements. We also excluded passive somatosensory stimulation, which included weight-bearing tasks, thermal stimulation, any pneumatic compression, vibration, peripheral magnetic stimulation, and acupuncture, and so on. We also excluded other forms of passive stimulation, such as rubbing the limb, icing, and mirror therapy. So in this systematic scoping review, we identified 10 studies that had various designs. So in this systematic scoping review, we identified 6 training strategies that combine, movement and somatosensory training. So the first one included tactile stimulation or discrimination, where there was active exploration of by touch, more precisely texture and pressure discrimination. The studies also delivered proprioceptive stimulation or discrimination, more precisely limb and joint position sense, hand configuration, as well as the activation of proprioceptors in the muscles. There was also a haptic object discrimination, which included the active exploration of object by touch, more specifically proprioceptive and tactile discrimination. Motor training included generalized mobilization. There were also functional training that focused essentially on practicing activities of daily living. And there was only one study that included a few components of integrated training, that is, where motor and somatosensory training were integrated together. So in this training component, they combined tactile discrimination or proprioceptive discrimination with movement or functional training. So in this scoping review, we found out that there was very little consistency across what were combined in the somatosensory and motor training interventions. Most significant improvements were observed in studies that delivered multiple active components and those that delivered the largest dose. It was also observed that most of the studies combined movement and sensory training sequentially, which led to modest gains, and which basically means that maybe the functional improvement were not maximized. The scoping review also kind of indicated that combined somatosensory and motor training, when combined synchronously, may optimize upper limb recovery. So this led us to develop a new intervention that combined movement and somatosensory training in a synchronous manner. That is, the motor and somatosensory aspects were integrated within the same task. So in the composed intervention, we combined 2 motor parameters with 3 somatosensory parameters. For the motor parameters, we used a short object distance with a longer object distance, and a small object width of 5 centimeters combined with a large object width. These motor parameters were combined with 3 sensory parameters. The first one included crushability, where we used a soft cup, plastic cup, and a hard plastic cup. The second one was texture, where we used rough sandpaper, so different types of roughness of sandpaper, and different materials that were smooth. For instance, we used felt and velvet. And for friction, we used slippery materials such as Teflon and non-slippery materials such as rubber. We also delivered training of 3 types of graded pressures. That is a preferred pressure applied onto a cylindrical object. We use the tactile device for this purpose, as it provides online quantification of grasp pressures, and I will be elaborating on this later on in the presentation. So the motor and somatosensory parameters were combined and organized in a standardized training matrix. So each arm of, as you can see in this figure, represents one combination. For example, a small object width combined with a short distance, and combined with, let's say, like texture, a smooth or rough texture. So that the motor and the somatosensory functions are coupled in action. So in this, in the composed intervention, we basically practice reach to grasp, and the delivery of the combined somatosensory and motor variables were integrated. That is, they were integrated within the same task. So in all, there were 36 combinations of the somatosensory motor variables. And it is also important to note that prior to delivering this intervention, it's important to assess the types of deficits and also the variety, the severity of the motor and somatosensory deficits prior to the intervention. This is because maybe someone doesn't have difficulty in discriminating between a soft and a hard surface. Or maybe someone doesn't have this difficulty in discriminating between a slippery or non-slippery surface. So you don't want to practice something that the person is already good at. In the composed intervention, we also provided augmented feedback on all trials initially, and then we faded this feedback just because we don't want people to become dependent on this feedback. So in all, we targeted 216 repetitions per session. Having said that, not everyone is expected to start at 216. Some people, we have noticed, started at maybe 20, and then they build up and gradually increase the number of repetitions as they go across the different sessions. So 10 sessions were planned over a period of 3 weeks, and each of the sessions lasted an hour and a half. So in the composed intervention, we provided targeted feedback using 3 strategies. Firstly, we provided online sensory motor feedback using the tact array, where we provided feedback on the tactile pressures at the fingertips. And like I mentioned before, we trained on 3 types of graded pressures, preferred, minimum, and maximum, and we used this device to provide feedback. And I have a short video later in the presentation to provide a more detailed description of this. We also provided online motor feedback using the ARM device, which stands for Arm Motion Measurement Device. So this was a kinematic measurement device that was developed by Dr. Paulette Van Vliet at the University of Newcastle. And we used this, this setup that has got markers and sensors that communicate via Bluetooth to a phone that provided kinematic measures such as movement duration or peak aperture. We also provided a sensory feedback offline, where we use the principles of sense training therapy by Dr. Leanne Carey to provide feedback on accuracy, the critical difference, and the method of exploration, as well as calibration. And in this part of the feedback, we focus primarily on crushability, texture, and friction. So we evaluated the impact of the composed interventions on the upper limbs after stroke using a single case experimental design. So we evaluated 5 participants, and we measured changes between the baseline and intervention phases using outcome measures such as maximal tactile pressures, where we used the tactile device for that. So the tactile was used both to provide feedback during the training, but it was also used as an outcome measure. And we also had other standardized clinical measures for motor and somatosensory function, such as the ARAT, the Wolf Tactile Discrimination Test, the Wrist Position Sense Test, Box and Block, and so on. So when it comes to the baseline characteristics of our participant, it was quite interesting. So they presented with different types and severity of deficits. So 3 of our participants had substantial motor deficits, and 1 of them had mild somatosensory tactile deficit. The other one had moderate somatosensory tactile deficit, and the third one had severe somatosensory tactile deficit. The other 2 presented with mild motor deficits, one of which had mild somatosensory tactile deficit, and the other one had severe somatosensory tactile deficit. So what did we observe post the composed intervention? We observed that all participants improved in 3 to 8 of the outcome measures. 4 of the participants showed improvement in at least the maximal tactile pressures, at least one somatosensory clinical measure, and at least one motor clinical measure. So the improvement in the maximal tactile pressures demonstrated a net change between 0.7 to 8.2 across all participants. And for the clinical measures, we found a range of improvement between 10% to 92.5% in 1 to 3 participants. And these were primarily observed in the Wolf Motor Function Test, the Grip Strength Motor Activity Log, the Tactile Discrimination Test, and the Stroke Impact Scale. So what does this imply for rehabilitation? This study basically indicated that the composed intervention may improve upper limb recovery after stroke. We also want to emphasize the need to assess for the types and severity of deficits prior to the intervention delivery, because this is going to allow you to target specific deficits rather than training people on tasks that they're already good at. The standardized training matrix can be adapted for a partial delivery of the intervention. We should also adjust the choice of the somatosensory motor combination to specifically target somatosensory motor and finger force control deficits. And when it comes to the amount of practice, we can adjust the amount of practice with regards to the severity of the somatosensory and motor deficits, respectively. So before we go to the third objective, should we take a few questions?
I've got another one for you, just going back to the systematic review you talked about. I noticed that mirror therapy was not included as an active intervention when you were choosing your inclusion criteria. And I know that there is one randomized trial in the Cochrane review that Sue Doyle did, where sensory training was done with mirror therapy for 2 weeks with good results, where people were actively exploring with their good hand, looking into the mirror, exploring textures, exploring shapes, and the other hand was simulating those movements and that amount of pressure. So why did you not include mirror therapy as an active intervention in your systematic review?
Yeah, so based on the criteria as we defined active somatosensation, we were looking really for active exploration with the affected hand. Now, with the ISRA roundtable, there's been quite some debate about how inactive is mirror therapy. So I think it's important to emphasize that when it comes to training of somatosensation, there needs to be more work done to study the mechanisms of actions of those different modalities. And the same would apply for mirror therapy. So at that time, we excluded it because we wanted an active exploration where there's, you're moving your fingers, you're doing something with your fingers or hand to explore a certain task. So that's the reason why at that time mirror therapy was excluded. So, well, I guess like it depends upon what criteria you set for your scoping for your review, basically.
I'm curious to know, are there more trials now using mirror therapy for sensory training, or is that the only one?
there are some studies that are still coming up. I think I recently reviewed a few from Asia that's been using mirror therapy with some good results, and that's the reason why I'm saying like we need to better understand the mechanism of action. So doing something is great, but understanding what like how it causes those changes like physiologically is also important. So I think it's worth exploring, definitely.
Yeah, yeah. Now, in your intervention, the compose intervention, I'm interested to know you're running it for an hour and a half. A typical session was an hour and a half, and the total number of sessions was how many?
10.
10. At what point in the 10 sessions did people start to show change? Does it take quite a few sessions, or is it completely variable?
I think it was very variable. And one of the reasons was that an hour and a half was quite intensive. So maybe, in the beginning, they showed like a lot of, I wouldn't say a lot, like some important improvements, but then they get fatigued, right? By the second week, it's so intense. Then we observe like a drop. And then eventually, like, because they become more tolerant to the intervention, they pick up again. The other factor that influenced the outcomes was the I forgot the word, the sensitivity of the outcome measures. So a tool like the ARAT, for instance, is quite crude, right? So it doesn't necessarily pick up like small sensitive like changes, especially because we were assessing them like every week. So that's another reason. But overall, if we looked at from the baseline to the end of their intervention. Some of them, like I said, did show some good improvement, especially when it came to their grip forces and the gross controller forces. But a little bit more varied when it comes to the standardized clinical measures.
Mm-hmm.
And the other thing I would like to add as well is the the variation in the severity of the deficit. So not only in the type of deficit. So that's the reason why I showed that image figure earlier where each of those participants had different like combinations, right? So the way they responded to the interventions really varied based on their baseline deficit, which there was no how to say typical trend that we observed that way, because it was also a very small sample size.
Yeah, yeah. I mean, and that's what you see with motor impairments too. There's such a big variability. The other thing, just before you go on to feedback, we were talking the other day, and we were doing the prep session about how we know that lots of people with stroke have cognitive impairments, and a common question from therapists is, so, can you use this with somebody who's got sensory impairments, really? But the reality is that many people will have cognitive impairments, and that's, we have to assume that that is going to be part of their profile, if you like. And you were saying that depending on how alert people were on that particular day, how well they'd slept, affected how they responded to the training.
Yes, absolutely. I do think cognitive function is really essential. There's in understanding and learning from this intervention. There's quite some literature now coming up when it comes to somatosensory cognition. I think that's a new term that's coming up. So in my postdoctoral research, I have extended the composed intervention to incorporating cognitive training. So we are combining movement, smart sensation, and cognitive training to see, how people's somatosensory and motor function improves. So when I'm going to be talking about the feedback, then you'll see how when we explore those different surface properties or even the kinematics, it's very important for people to be able to understand those questions and be alert to be able to respond. And we are not necessarily interested in a right or wrong answer, but more about how they reason to be able to come to providing us with a response. So that reasoning ability is, basically like highly dependent on the cognitive function. So I think more and more we should be including the cognitive component in our intervention, at least evaluating that to make sure that we're able to communicate to a certain at a certain level, so that the participant can also our patients can also understand and learn from those interventions.
Okay. I can see there's one question from one of our participants about the inclusion criteria for your 5 participants, whether they had spasticity or not, and also how did you manage fatigue? And I can see somebody else putting their hand up. I'm afraid you can't talk to us, but you can type your question in the Q&A if you have a question.
So when it comes to spasticity, we didn't have any restrictions with regards to that. So we did evaluate for and control for spasticity. We didn't see any change per se, so no worsening, but they stayed the same. So even in my postdoctoral work, having spasticity is not an exclusion criteria. We would still like work with them and facilitate whenever needs be. When it comes to fatigue, yes, we have to dose the intervention appropriately. So like I said, I wouldn't necessarily start with 216 repetitions in an hour. So based on those 5 participants, I think 2 of them we started at 20 and then eventually built up to like 75. That was the maximum they reached. And 2 others were able to reach like higher numbers. So we can have a target, but it doesn't necessarily mean that people are going to be able to reach for that. So one of the ways to manage the fatigue is to build the number of repetitions, but also if we're including like cognition in it, we have to also take into consideration that there could be like cognitive fatigue. This kind of intervention does require a lot of intrinsic kind of like communication, intrinsic feedback. So if we see someone, is getting fatigue, we provided breaks during the intervention, but also we provided a day break in between the sessions. We found that providing like consecutive sessions, so let's say like 3 consecutive days is not necessarily beneficial as compared to providing the intervention at intermittent days and giving them an opportunity to rest. One of the experiences I had in the beginning when I was piloting the intervention was I had a participant who had moderate to severe somatosensory and motor impairments, and I tried to reach about 100 repetitions with that person. And by the end of the intervention, the person couldn't actually lift their hand up. They couldn't produce a grasp. And this is obviously terrible, right? Because you don't want your intervention to exert someone to such an extent that they go home, they are unable to do anything. So that pushed me to scale back on the number of repetitions and really dose it to how the person is performing on that day, what was, their sleep like, what do they feel like on that day. And then push them a little bit to see, if we can push a little bit more, but not overdoing it. So overdoing it would be a big no-no.
Yeah. And just one last comment and question before you go on to feedback. That question from the person about working with people who've got spasticity or who've got an overactive hand and it's quite tight. I know in Leanne Carey's Sense program, she physically helps people to feel surfaces by, holding their hand and rubbing their fingers over or around objects. And did you have to do the same with people who are quite severely weak?
Yes, absolutely. So there would be, some hands-on facilitation whenever required. And at times, we noticed that in the beginning, they might need some more hands-on facilitation. But then as we get through the intervention, they learn how to do the task, and there's a little bit less of facilitation. One of the things that I keep in mind when it comes to spasticity is I don't necessarily focus on doing the task fast, because there's that's going to work against the person. So I take the time to make sure that I work at a preferred speed or at a slow speed to be able like to get, a proper reach, a proper hand opening, because at the end of the day, I want the person to have a successful task performance rather than focusing on speed that way. If there are secondary changes, though, as a result of spasticity, then that's a bit more complicated, right? When there's secondary changes and stiffness, then that becomes a lot more difficult to manage. In one of my participants at the moment, in my postdoctoral research, that person does have very severe spasticity, but has been having a few doses of Botox, and with the Botox combined with the intervention, that was a great combo because I was able to, facilitate less, and the person was also able to, like be less exerted, less fatigue, and was still able like to complete the task to a larger extent. So having that combination of Botox can also be helpful at times.
Thank you.
All right, so this brings us to our third objective, where I'll be discussing a little bit about how to structure feedback to assist in exploring motor and somatosensation. So as I mentioned earlier, in the composed intervention, I use the Tactary device to deliver feedback. So the Tactary is a commercial device made by a US-based company, and the setup is quite easy. So you have a cylinder here. I think I can't see my cursor, but you can see like the figure A is a cylinder. It has a cable attached to it, and the cable is connected to the gray device there. And this setup is connected via a USB cable to a computer. So we trained 3 types of gross pressures. The preferred pressure, which is the amount of pressure that a person chooses to pick the cylinder up with. The minimal pressure is the amount of pressure applied on the cylinder just before it starts slipping away. And the maximum pressure is a pressure when you squeeze as hard as you can. So this visual display of the gross pressures is actually very helpful. It shows a pressure distribution map, which is color-coded to indicate the amount of pressures, the intensity of the pressures, just like a heat map. So it also shows a time pressure profile across the gross duration. So the Tactary is basically referred to as the Tactary pressure distribution system. It's a sensor-based technology, and it provides a new way of quantifying deficits in grip strength. So the Tactary is made up of very thin conformable force sensors that provides data about hand pressure or finger pressures on objects over time. So one of the advantages of the Tactary is that because it is made of what we call capacitive sensor arrays, it makes it very sensitive to any changes in tactile pressure. So up to like 1% change in pressure. So it allows us to detect small changes in tactile pressures or forces when it's applied through the tip of the fingers. So originally, the Tactary system was used to train surgeons to operate on tumors. So this is how sensitive the Tactary is, that it was actually used to train surgeons during surgeries. So in this video, I'm going to play the video.
And can I just check if there's sound on the
I
video
can't
or
even
not?
see the play button though.
Maybe
Oh,
down.
there you go. All right.
Should we hear
So,
any sound or not?
no, so I'm going to be talking over it. All right. So here we can see the person is holding the Tactary device with the affected right hand, and is performing maximum gross pressures. So as he presses onto the device, we see a display of the pressures from each finger. And we can see how much pressure each finger is applying, as well as the area of the finger that is being used to apply this pressure. So with the visual feedback, the person can adjust the amount of pressure as appropriate. For instance, he can do the same task with the less affected hand which would be considered as the near normal hand, and then compare to see what adjustment he would need to make with the affected hand, so as to make to calibrate those pressures across both hands. All right. So here is what the online feedback would look like. You can see in a few seconds, I'll wait for it to come up. You can see that here the thumb is applying quite an important pressure, whereas the last two fingers, that is the ring and the little finger, are barely pressing onto the object. This device allows us to see also the spacing between the fingers, which is important for finger positioning so as to hold an object in a stable manner. So this hand pressure profile also allows us to see grasp formation, how the grasp forces are being sustained, and the grasp release as well. So here in the second graph, we can see that towards the end of the graph, the pressure kind of like drops down, which indicates that the person is not able to sustain that pressure. So this visual display can allow us to identify deficits in grasp formation, in sustaining of grasp forces, as well as observing deficits in grasp release.
It's an amazing device, Tactory. I looked it up on the internet, Sandhya, and they use it for things like testing the softness of avocados, and they use it, as you said, in surgical procedures, and they use it on pads where people have to press a particular amount of pressure for on-off buttons. But it's quite expensive, I think. It's not something we could easily just buy. It's what, 20,000 or?
I think it would probably be a little bit more now, depending, how many devices we're looking into. But there are a few options which I'm going to discuss. But just come back to your point, this tactile pressure distribution system is also being used in sports, in racket sports, for instance, to look at, how much pressure is someone applying on the handle of a racket. So in different types of sports. I even saw earlier today that they actually use it on surfboards to look at training, surfers, like right in the ocean, looking at how the waves kind of like hit the surfboard. So I guess there's different kind of things that you could do with the tactile. So yes, indeed, the tactile can be a little bit expensive, but there are other options in the form of haptic gloves that are available. On some are commercialized already, some are still like prototypes being developed. For instance, the Hero Glove is a product of the Toronto Rehabilitation Institute that allows someone to hold, a plastic bottle, to hold a stylus here. The Rappel and the Sensor Glove are US-based products, and they also provide haptic feedback. So they have got sensors that measure the amount of forces that's being applied to an object and feeds this back to the person via different interfaces. They are at times combined with virtual reality or augmented reality using like gamified approaches as well. So for the last part, I wanted to touch a little bit about the structure of feedback. So in the composed intervention, I developed a set of I'll avoid using that word. A set of feedback to help the person to learn from exploring the motor and the somatosensory combinations. So I use the sense therapy principles, which focuses on the accuracy, the sensory attribute, the method of exploration, and calibration. So for instance, to explore the crushability, I devised a set of questions that would help the person explore this specific property. I start with usually a general question. Do you know what this object is? Are you able to crush it? And what type of material do you think this is? And then I focus on the critical difference of that sensory attribute. For instance, is it easy or hard to squeeze? Or what helps you know that this object is hard or soft to squeeze? So my aim is not to get the right answer. My aim is to guide the person to explore how he gets to the answer, to be able like to feel what's happening at the tip of the fingers. So I guide them about the method of exploration. So for instance, for crushability, they have to press towards the object and then release a little bit, feel the amount of give way, behind their fingers. Or if it's a hard object, there wouldn't be any give way under their fingers, and that's what they should be able like to sense. And then also calibrate that with the less affected hand, compare that, and get them to retain that sensation when they're practicing with the affected hand. Now, this is a hard thing to do because it's a very intrinsic thing. We're trying to teach someone to sense a sensation that we as therapists, we are not feeling it, but we can guide them through the question. So I applied the same principle when it came to kinematic feedback. For instance, I use that for to provide feedback about movement duration or even extent of grasp approaches. For movement duration, I ask them, how slow, fast did you feel this task? Did this task feel? I would give statements like you took this amount of seconds to reach the object, or you took longer to reach the cup. Next time, move faster. And then I bring them again to the actual sensation of movement. So I'm teaching them how to not only sense sensation, but also sense movement. Okay, how do you know that you move fast? What helped you know that you move fast? Maybe you felt a bit more strain at the level of your biceps, or more effort at the level of your hands as compared to when you move slower. So there are a set of questions that I have devised to help structure the provision of feedback in the composed intervention. All right, so this brings us to the end of this presentation. Well, thank you very much for attending, and I'm open to more questions.
Thank you, thank you. Just for the benefit of the audience, I've got two people I've worked with who I'm going to show you on video, and then get Sandy's
yes.
expert advice about them. First, a question for you. You mentioned that you talked about spacing, giving people feedback using the tact array system about the spacing of the fingers. And certainly I notice when I'm training people with reaching, people do abduct their fingers, even for something that's very small, such as, a jar like this, they will have some spacing between their fingers. So is that an important part of being able to accurately hold and adjust your pressure rather than having your fingers close together?
So it depends upon the size of the object. So if it's a large object, you would want your fingers to be more spaced, right? Because that gives you a more stable grasp. But if it's a smaller object, you might not even need all the fingers, right? You might need maybe like 2 fingers if you're picking up like, yes, a small jar, or an object as small as, the block in the box and block test. But what's important is that there's regularity in how the fingers are placed, and that they are not like crumbled, like 1 or 2 on top of each other. So they could be close, but not necessarily like, it shouldn't be like one on top of each other. So that's what we're trying to correct. So when you have that visual feedback, so obviously the person can look at their hands, but then when they look at the tact array in that visual display and they move their fingers, they can actually understand, oh, by moving my fingers, there's a little bit more space in between. And then maybe they're able to apply a better control of the forces. So if the fingers are together, like in this way, so the middle and the ring finger wouldn't be contributing to holding the object, right? And which could make it unstable, which could lead to a draw. So we use these strategies to help the person become more aware of how the fingers are positioned and how that impacts onto applying pressure.
Yeah, that overlapping of fingers, you'll see that in the lady I'm going to show you on the video who's trying to pick up a fork. She's got fingers overlapping, quite common. Another question in here. Actually, it's one I wanted to ask you. Somebody asked about the time post-stroke for the people in your study, the 5 people. I think they were all chronic, sort of months or years post-stroke. Is that correct?
Yeah, they were all very chronic, I would say.
Yeah.
So I have no restrictions usually when it comes to people with chronic stroke. And one of the reasons is that once they go past the 2 years, they don't get anything from the system. And
Mm,
most of the time, rehab is like really expensive. It's out of pocket, expenses. So
mm,
after 2 years, these people don't get anything. So after 10 years, they do even less, right? So, and I've noticed that when they start getting rehab, they do start showing signs of improvement. So that window of opportunity that we tend to focus onto, the first 3 months, yes, we can maximize during that phase, but beyond the 3 months or the 6 months, we can also do a lot to help people improve their recovery.
yeah. Somebody's asking, how do you adjust your training when somebody's got communication impairments?
Yes, so that's been a challenge. So when it comes to it depends what type of communication impairments, of course. So we have thought of using, very simple language. And at times we, have struggled like a lot with that because we're trying to explain a concept, and at times they do explain, but then they are not able like to give us, the response that would help us guide the person. So, and this is really a work in progress. I haven't found the optimal formula for that, to be honest, but I take it like in small chunks because it's as and when we're delivering the intervention, and that's when I'm trying to understand the person's communication impairments, and at the same time trying to get them to understand what I want them to do. So it has been a challenge so far. It's not an exclusion criteria for my study, but um, whenever we've had someone in our study with expressive aphasia, it has been quite a challenge. So it slows down the delivery of the intervention, but I think it's worth still exploring because we still want, the person to learn from this intervention.
I guess if you're giving them some forced choice, you can show them the 2 different cups with different surfaces on them and they can point instead
Yeah.
of having to orally say something.
So
Yeah.
some aspects of the training we can show them options, but then some aspects when it comes to the exploration where I want them to tell me what they're feeling under their fingers, and it's quite specific kind of information that we're looking for. That's when it becomes a bit tricky. So
Mm.
we slow down the intervention. We ask the person a question and then give them a few choices, multiple choices, in the questions, and then try to get a response from them, and then check that response again and again. And at times, I find that having a family member present can be quite helpful because they help,
Yeah.
like also in facilitating the delivery
Yeah,
of the
we've
intervention.
done in, in our constraint-induced movement therapy studies. If a family member can help them with both the consenting and also answering some of the self-report questionnaires because they know the person quite well, then they can participate more. Somebody's asking about how you determine people's eligibility for in terms of cognitive function. I think, did you use the MOCA as a screening tool or?
Yes, we did use the mocha, and I think our cutoff score was like 11. So so below that it would have been like really difficult, but at the same time I've had someone who didn't reach the cutoff, but he was like very old, and just as with aging itself, that presented some difficulties with regards to the communication itself. So yeah, so we could have like a cutoff, but I would say to really have one session with a person and then see, how well because the mocha was meant to be like for a screening, right? And it evaluates only specific aspects of cognition. So I would suggest you get the person to come in, deliver one training session, and then see how the person responds, and then make a decision thereafter.
Mm. The last question at the moment before I show you my videos, and I want to get your feedback on that. Did you get feedback for the good arm followed by feedback from the impaired arm? And are they looking at the object or not while they're doing the practice?
So is that for both the where we were practicing the gross pressures, or just for all of them?
I think just generally, yeah.
Yeah, so at all times we are calibrating with the less affected arm, like the good hand. So we follow the same therapy, sense therapy principle. So we start by doing the task with the affected hand, and then get them to explore, and then eventually get them to do the same task with the good hand, and understand the normal or close to normal sensation, and keep that sensation in mind, bring that into the affected hand. So we're always like changing in between. And it's the same thing that we did with the grading of the gross pressures as well. So at times people, overcompensate and press a lot harder, but they are not aware that they are pressing a lot harder until they show it, they see it on the heat map, or when they compare it with the other hand, right? Especially
Mm,
when it comes to preferred pressures. So we've noticed that for those who have got a bit more of tone, they tend to overcompensate. And
mm,
so we want the preferred pressure in the affected hand to match the one in the good hand, right? So often we need to get them to release that pressure. But for those who have got a bit of a weaker hand, it would be the opposite. So we want them to squeeze a bit more so as to match the good hand.
yeah, yeah, yeah. So if it was my mobile phone, for example, it would be the edges. I'd be exploring the edges and the little tag here and trying to get my affected hand to recognize those edges and those different textures. Okay, I'm going to show you the first video is a man that I worked with. Oh no, the first video is a lady I worked with who has got that overlapping finger problem. And the first video I'll show you was this was in a workshop, and so we're doing mostly motor training. She's picking up the fork. She's able to successfully pick it up, but you can see her grasp is not very accurate in terms of the opposing forces, and the way she holds the handle is problematic.
Yeah.
So the second video is a slow motion video, so you get a bit more idea about how disorganized her pre-shaping and the size of the pre-shaping and where she places her fingers are. So would you like to comment on that before we go on and look at the training videos as well?
Yes, absolutely. I mean, when you look at the video that has been slowed down, the way the person approaches, there's a really nice, a finger opening, hand opening, but then it's the closing around the object that becomes a bit more problematic, which lacks that smoothness, right? So I think it's the
Mm,
the middle finger that stays like flexed the whole time. Um, and so I would say that I would do a part training, a part practice before putting the whole task together. So really practicing, the finger opening, but also the closure. But then the moment I would see uh, like the impairment setting in, I would interrupt the task so that they don't complete the task with that altered kinematics. So the moment their fingers start coming together, if it's not a smooth hand closure, I would interrupt the task until there's enough practice so that the fingers
mm,
come together in a more smooth manner.
mm. Yeah, sometimes I'll tape people's fingers together so they can try to train them together as a virtual hand, as a virtual finger, if you like, and that can
We
sometimes
could do
help
that
people
too.
get.
Or
Yeah.
or also train like individual fingers as well. So picking up a fork is kind of
Yeah.
like a hard task because like it's such a thin handle, right? So maybe
Mm,
train with like larger handles, and also um a fork that, like, let's say those wooden forks, because it has got a bit more of a grip, and then eventually go to the metal one. just so that
Yeah.
they understand the formation of the grip, the stabilization of the handle in the hand, and also that pinch, the opposition between the thumb and the index. That's a hard one to do on a very thin metal
Mm.
fork, right?
Yeah, so the next two videos are the training that we did. And so this, we've turned the fork sideways because it was easier for her to pick it up when it was in this plane rather than in the previous position. And we put a non-slip mat underneath. And so what she's trying to do is to practice getting her thumb and index and middle finger opposed. And then the final video in this series is with a slightly thicker handle that's a little bit less slippery. So you can see she's overlapping still. And that was one
Yeah.
of the instructions, was to see if, and the goal was to see if she could do that without the index and middle finger being overlapping when she made physical contact at the point of grasp. So she's a little bit better there. She starts better, but she still wants to help with the middle finger. And I think we see it one more time.
So it does get better with time. It seems like there's definitely effort in trying to keep their fingers separate, especially their index
Mm.
and the middle finger. And it's only when it's actually positioned on the object that it kind of like overlaps a bit.
Yeah,
So maybe slowing down this whole movement, so approaching the task, and also looking at the hand. So I think as the person has been practicing, the positioning of the fingers in space was getting better, but when it comes to positioning onto the fork itself, that's when it gets a little bit more messy. So really practicing that the index and the middle finger spaced onto the fork. So just doing a part practice, practicing that before actually putting the whole task together. But the good thing is that when you practice a whole task, that's when you can actually see where all the deficits are, right? So
yeah,
identify those deficits and then maybe work on one or two of them at a time, and then build up towards the bigger task.
yeah. And the last one here is slow motion, but she's now been practicing the third video you see. Now she's on, this is the next day. Still disorganized finger opening. And again, she's trying to get the fingers side by side
Yeah.
on this side of the fork and her thumb opposing them. Still having trouble, as you can see there. So yeah, your point about practicing getting the fingers side by side and not overlapping when she's doing the pre-shaping and just at the point of grasp before she lifts it, and not practicing the lifting so much.
Yeah.
And then go on to
What
the,
another thing that could be done is to have like position targets onto the fork, even though the
uh-huh.
fork is like quite small. So just have like little, you can mark it with a pen, and just to so the person can learn where each finger would go, and
Yeah,
then gradually reducing those feedback aids so that the person can learn by doing some mistakes and then self-correction as well.
yeah. So we could just use the blue mark, the blue tape is for the middle finger, and the pink parts of the handler for
Yeah.
her other fingers. And then the last two videos are her practicing with the grasp around the handle, which was problematic. You could see she was holding like that rather than like that. So she's trying to position her fingers along the handle of the fork. And then the last video here is just practicing without the fork, seeing if she can actually maintain the finger position, which is still very hard for her. And her ring and little fingers, which is quite common, were more difficult for her to hold consistently. So that's about
Yeah.
the training that we did with this lady. And so I've got a few more ideas about what we could do. I'll show you the second man who was part of a constraint therapy program. And here he was working on a number of tasks that he'd set as his goals. He couldn't get his car keys out of his pocket very easily. His hand kept sliding down the side of his trousers and wouldn't go into the pocket. So here he's practicing doing a 30-second time trial in the CIMT program and seeing how many times he can successfully get the keys out of his left pocket. And I think he manages twice in 30 seconds. And you were saying when we were watching this the other day that it's quite common you would put your hand down and you would feel the shirt and then gradually you would get your fingers into the pocket. So that's quite usual that you would see that kind of behavior. But it just takes him 2 or 3 goes to feel the difference between his shirt. And you'll see this in the second video too, a bit more closely.
Yeah, and at the same time, I suppose he's not necessarily looking at where his hand is going, right? So he's really relying on his proprioception and also feeling the shirt. Like the shirt is almost like an obstacle in the way.
Mm,
Um, so he has to pull that up and then slide the hand in, right?
mm, yeah. And then the
But
last
if
video is just him
Mhm.
in sitting, just so you can see how he managed there. So he did get a little bit quicker with that, and he could certainly feel using the leg. The leg gave him some cues where his keys were, so he could find them. It was much more difficult if he had to use a jacket pocket where he couldn't push it against his leg so much.
Mhm. And I guess like in a sitting position, there's probably a little bit more awareness of where the hand is with regards to the leg. For instance, kind of like it feels like a little bit like closer. Um, but the challenge I find is that the pocket feels a bit smaller when you're sitting, right? It's always like a little bit harder to wiggle your hand in. So that could be like a really nice increase in a level of difficulty of the
Yeah.
task, which would provide a nice like motor kind of like challenge. The aspect of the sensory part of this task, I I would say that you could, even start with a bunch of keys, but then eventually get the person to identify like one specific key, like the largest key or like the smallest key,
Mm,
and in a very restrained space, right? So it means that his fingers would have to make very fine, small movements to be able to identify the features of that key, the size of that key, before being able like to get it out.
yeah. Okay. Last question, and then I've got one to ask you before we finish up. Somebody's asking in tele rehab about the feasibility of doing this by tele rehab.
Like the compose study. So we've had in one of our qualitative studies, we did ask the question to patients. Um, we were thinking of developing a kit. That's one way of going forward with that. But then that kit would need to also present with a variety of tasks, a variety of objects so that we can actually progress the level of difficulty. So it is possible, but there would need to be someone assisting the person over there, because when you're presenting the object, you're getting the person to close their eyes or to wear a blindfold, so that the person doesn't know if the person sees the object, kind of like gives it away, right? So you're working without vision.
Mm,
So you can have someone, to you can identify the objects. Say, I want you to show object number one, and then that's what the family member would present to the person. So there are possibilities. It's a lot harder, to be honest, but for part of the task, maybe not the whole task, some of those tasks can be done through tele rehab, provided we develop a
mm,
kit for that.
yeah. I think we might stop there because we're a little bit over the hour. And I know that people don't generally listen to recordings longer than that, but we've still got nearly
Okay.
60 people here, so that's great. Thanks very much. It's been really interesting, and I look forward to hearing from you about your future research and your current research over the next few years.
All right. Thank you very much. Well, it's a pleasure being here. Thank you.
I'll stop the recording.